Hello, let's discuss history taking for dysphagia. Dysphagia is basically the difficulty in swallowing. So let's discuss the history taking of dysphagia. We can use this acronym to take dysphagia history. D for dysphagia details. So in this dysphagia details, we will ask about the onset of dysphagia. Okay, then we will ask about the dysphagia. Is the dysphagia to the solid or liquid or both? Okay, or both. So if there is dysphagia to both solids and liquids, from the very start, okay, then we will think about the motility disorder like achalasia or the esophageal spasm. But if the dysphagia is first to the solid and then progresses to the liquids also. First, if the patient complaining of the dysphagia to the solid first and then liquid also, so the solid dysphagia which progress to liquid also, then we will think about some mechanical disorder or mechanical obstruction like esophageal cancer or stricture or esophageal ring or web. Okay, so if the dysphagia is to the solid and liquid both from the start, then we will think about achalasia or esophageal spasm, which is motility disorder. And if the dysphagia is to the solid first and then progresses to liquid also, then we will think about mechanical obstruction like esophageal cancer, stricture, ring or web. Okay, so this is about the dysphagia to solid or liquid. Then we will also ask about the location of dysphagia. We will ask from the patient then whether there is difficulty in swallowing or whether they feel the food to stuck in the throat or the chest. If there is throat symptoms, okay, if there is throat symptoms, then we will think about oropharyngeal dysphagia. It is one of the type of dysphagia, oropharyngeal dysphagia. Okay, but if there is symptoms, if the patient complaining of chest symptoms like heartburns, okay, acid burns, chest pain, then we will have to think about esophageal dysphagia. Okay, so in the dysphagia detail, we will have to ask about onset. When did dysphagia notice first? Is it to the solid or liquid or both? If there is dysphagia to both solid or liquid from the start, then we will think about motility disorder like achalasia and esophageal spasm. But if the dysphagia is to the solid first and then progresses to liquid also, then we will have to think about some mechanical obstruction like esophageal cancer, stricture, ring or web. Then we will also ask about location of the dysphagia. If there is the patient feel the food to stuck in the throat, then we will have to think about oropharyngeal dysphagia. But if the patient feel it in the chest, or he or she feel the food to stuck in the chest, then this will be esophageal dysphagia. All right, then the dysphagia detail. Then why is the yucky associated symptom or yucky esophageal symptoms? Okay, in this portion we will ask about the esophageal symptoms. Okay, we will ask about the esophageal symptoms. So we will ask about the, after the dysphagia detail, we will ask about the esophageal symptoms. Like the acid burn, we will ask about, is there any acid burn or heartburn, any bitter taste at the back of their mouth. We will also ask about odynophagia, which is pain while swallowing, odynophagia. Okay, and our chest pain after swallowing or around meals. Okay, so in the esophageal symptom we will ask acid burn, heartburn, bitter taste at the back of the mouth, odynophagia, or the chest pain. Okay, so if the patient has acid burn or heartburn, then it will indicate the peptic stricture resulting from GERD, gastroesophageal reflux disease. Okay, if the patient has long-standing GERD, then it will lead to peptic stricture, and the peptic stricture will represent as dysphagia. Okay, but if the patient has, we will also ask about regurgitation. So if the patient has regurgitation of the undigested food, then it will indicates achalasia. Okay, if the patient has pain on swallowing, odynophagia. If the patient has odynophagia, it will suggest esophagitis. Odynophagia will suggest esophagitis, infection, or malignancy. Okay, so this is about the esophageal symptom, yucky symptoms, or yucky esophageal symptoms. Okay, so after the esophageal symptom we have to ask about the swallowing complications. So let's discuss this swallowing complication, that what we will be asking in this swallowing complication. So we have to ask about any coughing or choking episodes during meal. Okay, so we will have to ask about coughing or choking. We have to ask about nasal regurgitation of food. If there is any food coming into the nose, then this will be nasal regurgitation. So we will ask about coughing and choking during meals and nasal regurgitation. We will also ask from the patient about chest infection. If they have recurrent chest infection, then it will show the aspiration of the food. Okay, so this is about the swallowing complication. So now if the patient has coughing or choking or nasal regurgitation, then it will indicate the oropharyngeal dysphagia. Oropharyngeal dysphagia. Okay, oropharyngeal dysphagia. And if the patient also give history of recurrent chest infection, then it will suggest the aspiration, one of the complication of the dysphagia. Okay, so this is the swallowing complication. After the swallowing complication, we will go to the past history. So what we will be asking in the past history is about the past history or previous history of reflux disease like GERD. We will ask about the any acid burn or heartburn in the past. We will ask about any neurological disease which can lead to dysphagia, neurological diseases like myasthenia gravis, stroke. Okay, we will also ask about multiple sclerosis. Okay, we can also ask about motor neuron disease, MND. Okay, so in the past history, first will be GERD, then will be neurological diseases, then we will also ask about any radiation or surgery in the past to the head and neck. Okay, when there is exposure of radiation or any surgery of head and neck region, then it will lead to the stricture formation, then and the stricture can lead to dysphagia. Okay, mechanical obstruction. Okay, so we will ask about GERD, neurological diseases. We can also ask about the autoimmune connective tissue diseases, which is scleroderma. Scleroderma can also lead to esophageal dysmotility, which can lead to esophageal dysmotility, which can lead to dysphagia. Okay, so in the past history, we will have to ask about GERD, neurological diseases like myasthenia gravis, stroke, multiple sclerosis, MND. Then we will ask about the radiation and surgery, and then we will ask about the scleroderma, which can lead to esophageal dysmotility. Okay, then after the past history, we have to ask about the Haem symptoms or red flag symptoms. Okay, the red flag symptoms is important in every surgical history. Okay, so what are the red flags for the dysphagia? Red flags for dysphagia are weight loss, unintentional weight loss, loss of appetite. Okay, any hematemesis, which is blood in vomit. Okay, any black stools, which is called melena. Okay, so these are the are any night sweats. So these are the red flags for the dysphagia. If there is any history of weight loss, loss of appetite, then we will have to think about some carcinoma, okay, or malignancy. Okay, if there is any blood in vomit or black stools, then there will be probability to have upper GI bleed. Okay, so this is about the red flags and the Haem symptoms. We will also inquire about the symptoms of anemia like tiredness and shortness of breath. Okay, so this will be Haem symptoms and red flags. After the Haem symptoms and red flags, we will go toward the past drug history, social history, and allergic history. So A for allergic history, drug history, and social history. In this history we will ask about the medications. This is important. The medication which can lead to dysphagia are the stricture. Okay, it can cause the pill esophagitis. So the medication, which one? NSAIDs. We will ask about any regular use of the NSAIDs, the bisphosphonate, okay, bisphosphonates, doxycycline, which is antibiotic. So these medication can lead to pill esophagitis, okay, and which can further lead to stricture and dysphagia. Okay, so in the drug history we will have to ask about the medication which can cause the pill esophagitis. Then we will go on to the social history. In the social history we will ask about whether they drink or smoke. So alcoholics and smokers, they can have the risk of esophageal carcinoma. So smoking and alcoholism lead to the esophageal carcinoma. Okay, so we will have to ask about it. Then genetic history, we have to ask about any family history of esophageal carcinoma or the stomach carcinoma. Okay, then after this, the last component which is important in every history is the ICE component. Ideas, IA, ideas, concerns and expectations. So we have to ask about ICE component from the patient, that what the patient thinks, what he has concern about, and what is he hoping for, expectation. Okay, so this is the history taking station for dysphagia difficulty. We have to we can use this acronym: dysphagia detail, yucky associated symptoms, swallowing complication, past history, Haem problems or red flags, allergic, drug history and social history, genetic history, ideas and concerns and expectations. So this is all about the dysphagia history thing.